Dr. Al Kurose is the president and CEO of Coastal Medical, a primary care-driven accountable care organization in Rhode Island. He's a graduate of Washington University School of Medicine and completed Brown University's internal medicine residency training program at Rhode Island Hospital in 1991. He's a graduate of the Yale MBA for Executives Leadership and Healthcare program, and he's a clinical assistant professor of health services policy and practice at Brown University.
So thank you all. It's really exciting to be here today. A couple of tough acts to follow, some really interesting talks. Mine is going to be just a little different in that I think the approach that I'm more familiar with might be characterized as a little more of a from the bottom up approach as opposed to a very high level, state level, policy driven, systematic, a little more top-down approach. So, but I think it's great to have those different perspectives. We can learn from on both sides. Let's see where I'm going with this. So, Coastal Medical briefly is a primary care-driven ACO. It's physician-owned and governed. We have 89 docs and 35 advanced practitioners. About 90% of those are primary care. We actually formed Coastal back in 1995. I was in a 2-doctor practice that was one of 7 that merged to form Coastal. We had 27 docs back then. But today our business is a lot different and a lot more complex. We serve 120,000 patients at 20 sites around the state. And really, I like the 6-word version of the triple aim that you see there. Better health, better care, lower costs, and that's really where we've been driving since about 2011. My own background is that I was a primary care internal medicine doc, again in that small 2-doctor practice back in '95, so I've sort of watched the organization evolve over time. These are questions that I was really putting out to the providers in this audience, and I tried to choose them because I think they're applicable whether you're just getting started or whether you're far down the road. Because when at Coastal, we obviously have to be assessing our performance on the triple aim as we make strategic decisions, and we have to think about what are the assets and sort of the unique historical context that we have that we can take advantage of, because I think either organization, any organization, whether it's sort of might be hospital-centric or it might be a community provider-centric kind of structure, is going to want to take advantage of their unique capabilities and assets as they go into transforming what they do. Who are the payers that are ready to work with you? In Rhode Island, we have had a cadre of commercial and Medicare Advantage payers that have been really good partners to us. They've offered us a lot of opportunities. What kind of data will we have access to? This wasn't true at the beginning, but we now get claims data from all of our major payers. That's an important thing to us. We do our own analytics. How are you going to pay for more people and technology as you do this? So one of my themes is you have to spend more to save more. You have to stop for a second and hold the audience. How many of you are providers or work with provider organizations? Okay, and of that, how many from hospital systems? And how many from physician groups or private practices, we would call it? Okay, so that's sort of interesting because that's the small minority in this room, but that's the way we've done it, right? We started from there and we've grown from there as a physician group. And I think that when I think about population health management and sort of rational models for pay for value, total cost of care, contracting. The model that we're familiar with is that patients are attributed to their primary care physician, and those populations for those organizations under those contracts are defined in that way, which is very different than the waiver system. And those are interesting models to put next to each other and think about. In any of these models, how are you going to engage patients? How are you going to engage your providers? How are you going to engage employers? These are all sort of, I think, common questions across that continuum of models. For us, again, we sort of start with engaging the primary care docs and their advanced medical home offices as the foundation for what we do. So this is a look at all of the Medicare Shared Savings Program ACOs in the country for 2015. If you look, the y-axis is quality scores. The x-axis is total cost of care per beneficiary. So there are multiple interesting themes to pull out of this. One is that there is a very large degree of variation in cost performance. You can see how far that spread goes horizontally. Happily, there's a little more clustering in terms of quality performance. The other thing that you probably can't see from the back, but I'll explain, is that the blue and purple geometric shapes are organizations that did not make money, and the orange ones are the ones that got paid. So there's a little bit of a design problem, in my opinion, with this program, in that, where you want to be is in that left upper quadrant, right? High quality, low cost. There are a lot of very high performing organizations that didn't get paid, and the reason is that they started out being good. So if you're going into population health management, you want to be careful about the payment model, because if you have to compete against yourself, and if you can only make money if you're going to improve, it's hard to do if you go in if you're already cost efficient. On the other hand, it's a great place to be if you're out here on the right side of the graph, because then you have tremendous opportunity for probably a decade. I'll talk a little bit more about payment models and some of that later. You can see where we sit. We actually had the highest quality score of all the ACOs in 2015. We were really happy about that. And I'll talk a little bit about what kind of processes we put in place to drive that level of performance. I pulled these from the publicly available data. If any of you are not aware, they actually publish the cost and quality performance of all the ACOs every year. So I saw that there were 5 ACOs, and I took a look at this, so I may have missed some of the detail, but I saw 5 ACOs that included Delaware, and that was a range of cost and quality performance. When you look at quality performance like that, certainly some of it's going to be just the challenge of measuring and reporting. I don't think anybody's really at 41%. I don't know who that ACO was, but it was probably a question of incomplete reporting. When you first start this work, that becomes a significant factor at the beginning. It's not just how well you deliver care, but how well can you capture that, report it, get rewarded for it. And as far as I could tell, there were no payments in 2015 for those ACOs, but again, that was the 2015 performance year. We now actually have our 2016 results, but they're embargoed until next month, so we can't talk about them publicly. So why did we decide to do this? We had 2 opportunities when we were thinking about this in 2011. We had the Medicare Shared Savings Program that was coming online, and we also had our dominant commercial and Medicare Advantage payer that was interested in offering us a shared savings type of contracting model that was very similar to what CMS was offering. And we sort of looked around and we said, well, gee, we have a bunch of the pieces already. We've been doing patient-centered medical homes since 2008. All of our offices were NCQA Level 3 recognized. We've been working on pay for performance on quality since 2007. We've got all our providers on the same EHR. We've had a lot of success with team-based care. We already had nurse care managers and clinical pharmacists. So we thought, well, we've got a lot of the pieces here. We also were fortunate, the state regulatory environment, the Office of the Health Insurance Commissioner in Rhode Island had implemented something called the affordability standards. I think that Rhode Island is still the only state in the country that has a dedicated health insurance commissioner. Everybody's got an insurance commissioner, but this is actually a health insurance commissioner with a dedicated staff that do a lot of important work. And they had mandated an increase in primary care spending. So we knew that the payers were obliged to spend more on primary care And we understood that they would prefer not to pump that money into fee schedules across the board, but rather make investments that would generate a return for them by driving care transformation and payment reform. So we sort of had a right opportunity environmentally. But I think that this last piece was the thing that really sort of sealed the deal for us. I mean, we are a physician-owned, physician-governed organization. Our board of directors meets once a month at night because everybody on the board except me is a full-time practicing doc. And we said, hey, look, our best path to financial success is going to be in these new models is to take the best care possible of our sickest patients, to offer them an array of services, the likes of which they have never seen before, because we believe that we could reduce total cost of care in that way by taking better care of those sickest people, and I'll get back to that. But that really sort of hit the values of our organization, and so we said, well, I think we've got the right environment, we've got a bunch of the pieces, this resonates with our values, so we're going to do it. And then we also decided right from the outset that we're going all in. We had a year where Blue Cross, and credit to them, were the first ones that were giving us stipends for nurse care managers in our patient-centered medical homes. I was still practicing primary care then. And so you would have these experiences where you have a patient who you're thinking is kind of marginal. Do I need to send them to the ED to be admitted? Could we manage them at home? And then you're thinking, well, if I want to manage them at home, I need to get them a dose of IV antibiotics and a breathing treatment. I need to make sure a nurse sees them at home today. Let's say it's a COPD exacerbation in a patient, probably provoked by pneumonia, but you're thinking we might not have to send them to the hospital, but boy, we've got a lot of work to do. And I've got this nurse care manager 20 feet away who could set this all up for me, except they're only for Blue Cross patients, right? So we thought, well, that doesn't work for us. So if we're going to do this new model of care, we're going to go all in. We also thought, boy, we're going to need a lot of resources to do this effectively, and if we only do it with a single payer and we just stick a toe in the water, we're never going to make enough, we're not going to move the needle and be able to actually get a return on this investment. So we decided, based on wanting to have one standard of care, that and to make this economically viable, that we were going to go all in from the beginning. And I think that our experience bears that out. At least in our circumstance, a toe in the water would never work for us. But what that means is taking a lot of investment risk up front. If you're going to try to create shared savings, you're going to have to execute over a performance year. You're going to have at least a 6 months claims run out, then a bunch of analytics and haggling and negotiation with the payer. And then somewhere around 20 months out from the time that you just started to deliver new services, you might or might not earn shared savings that would help you pay for that. So you really have to think about how we're going to pull this off, and do we as a provider group want to do this? So you have to have kind of a stomach for investment risk. And that's, people talk about downside risk, but they almost never talk about this. But I'll show you in a little bit the kinds of infrastructure we built to be able to do this. And we can talk a little bit about the cost for that. Actually, the contractual downside risk that we're now about to start taking pales in comparison to actually the cost of doing this work. So, on the other hand, I don't want to overemphasize the challenges because there's been so much opportunity. Actually, I would say I'm here to tell a success story, and we're really thrilled with how this has gone. And the best things to say about it as a doc is, I know that the care's gotten better. There's absolutely no question. Docs will tell you the same thing, and we've been able to be profitable in this. So, we wanted to go after the triple aim. We wanted the same resources for every patient. We knew with doing this new stuff that we needed the economies of scale. That was the argument against the toe in the water. The first mover advantages were significant because the payers saw us as being uniquely ready and willing to be able to do this work with them. And I think that helped us a great deal. And it did elevate our position in the market. People started to look at us differently. We weren't just another primary care docs anymore. And that made a difference too. And I think for us, being at the table with the payers, with the regulators, with the policymakers, being part of the local, regional, and national conversation about care transformation and payment reform, it's a righteous thing to do. It's consistent with our mission of being leaders in the community, but it's also, it's good business. You know, you want to be in that position. If you step out and go first, you may get some advantages that won't be available later. So working capital was an early challenge, as I mentioned. Happily, we've been successful in the first 3 years in the Medicare Shared Savings Program. We've earned $11.2 million in shared savings payments. Again, you know, they call it upside only in track one, but I told you that we're investing quite a bit. Commercial and Medicare Advantage partners were also really important, so we decided that we needed a portfolio of contracts to drive this. And it's a little like the concept of diversifying your risk, because with any given payer or any given contractor or any given performance year, you know, particularly if your populations aren't that big, you might catch some bad luck. But this way, you're diversifying your risk across a portfolio of populations, but at the same time, you're able to start to implement standards for all these patients along the lines of what Dr. Shah was talking about. Because I agree with him that with a lot of the things that he said, even though we're taking the bottom up road to getting to that place, I think standardization is hugely important. I think his emphasis on the value proposition to the patient and respect for their precious time and energy is crucial. So how do you do this? Well, we got the advanced payment model from the federal government, from CMS. That gave us $2.4 million over 2 years to work with. We got the payers to give us PM infrastructure support dollars. We got them to give us good quality incentive programs, or I should actually give the credit to them for that because they really put those in place. We were also able to work out stipends for nurse care managers, clinical pharmacists, and all those team-based care members are crucial to this. And to my mind, this is all actually intimately tied in with the physician experience, issues of clinician burnout. We're really trying to tie this all together with, so you take sort of a values-based approach to patient care, population management, you've got heavy emphasis on preventive care and coordination of care. You add in ways to be more efficient in the office to unload the providers, have them working at the top of their license. Team-based care helps you with that. Centralizing services helps you with that. And so we're hoping to accomplish all of those objectives. And so far we're making it work. It's a little bit like a juggling act because there's always uncertainty in these payment models that depend on your cost and quality performance. But again, I think some great things have happened for the populations that we serve and the docs that work for us and our staff. There's a lot of talk of bending the cost curve. This is our cost performance in the Medicare Shared Savings Program going back to 2009. I don't have the data for national fee-for-service until the 2012-2013 performance year because that's when we joined and got that data. But we had to submit and learn about our baseline data from 2009 through 2011 to enter the program. And so, and I'm not allowed to show you the 2016 data, but I can tell you that it's pretty similar to 2015. So we actually sort of peaked out on per member per year costs in 2011 at $9,600, and we're still, $800 to $1,000 less than that today. Our risk scores are a little above average for the program, so it's not because we're only taking care of healthy people. And so this is part of what's allowed us to be financially successful and make the good work sustainable. I'm going to take a few minutes and just let you see what we've been doing for new clinical initiatives. I want to leave time too for questions, so I can't go in detail on all of this, but this first page, Coastal 365 provides an urgent primary care visit for any patient who wants one every day of the year. We're open weeknights, Saturdays, Sundays, holidays. High-risk patient management, we've got, I think, 21 nurse care managers who, most of them are managing their own panel of high-risk patients. Transitions of care was taking about half the nurse care manager's time, so we created a centralized team to do that. Disease management programs for those conditions that you see have been very successful. Prescription refills centralized has been a huge winner. The docs love having that service. It's safer, it's faster, more efficient, and it removes distractions and interruptions from the doc's daily work. The only ones that go to them are anticoagulants and controlled substances, and this team does the prior auths too. We have nurse care managers out in the hospitals and in a restricted network of SNFs. We have a home visit program led by a nurse practitioner that sees 250 of our sickest patients at home. And there's more that I won't run through, but this is sort of the rest of that portfolio. Variation reduction is really interesting. We have a team that goes out to every office to talk to the providers about where their performance varies from their colleagues, and we've also revised the compensation formula, which has helped to increase engagement in that variation reduction conversation. And we would emphasize that the payment model doesn't need to dictate the comp model, and that we really design our comp models around our strategic goals as an organization. So care is really different. I have the pleasure of giving talks in Rhode Island, and usually people from the audience will stand up afterwards and say, yeah, I'm one of your patients, you guys really do this, and that things really are different, and these services really are cool, and I mean, that's why we did this. But it takes a lot of doing. So here's some of the people that work for us, none of whom bill for their services. We got 11 PhD level clinical pharmacists, 17 nurse care managers, I lied before. 6 nurses and 6 MAs are on our transitions of care team, 3 nurses and 7 MAs are on our disease management teams. We have 7 pharmacy techs doing the prescription refill. We have 2 social workers, 12 quality assistants. When you start doing this work, when you're a patient-centered medical home and then you decide you're going to be an ACO, if you dump all that extra work on the offices, they will eventually be crushed by the weight of that extra work. So we had a process back in 2013 where, you know, we brought in not only the docs but their staffs, and we said, so there were medical assistants and receptionists and office managers, and we said, we're hearing that the burden is getting really high. We know from our surveys and from talking to you that you think that the care is great, but what do you want us to help with? And that was actually where transitions of care and prescription refills came out of, and a couple other programs. That was what people told us they wanted. We as a leadership team thought a call center was a great idea. They hated that. We had people come and say, I know this is about, you know, transforming what we do, but I'm just here for one thing. I'm just here to make sure that you do not start a call center. What are we working on right now? We're working on call center. But back then, you know, that wasn't what people wanted, so why fight that battle? There was so much work to do. And so, you know, getting people support what they build is sort of a big lesson for us, and we try to do as much listening and collaborative interaction with the offices and their staff as we can. This is more stuff that is new and different and requires investment. So there's lots of new hires, there's lots of training, there's lots of incremental costs, and a lot of these roles didn't exist before, so you can't even necessarily hire people that already have the training. You really have to bring people in. So on the other hand, it's been great because our MAs have an advancement track that never existed before. They can move up to our transitions of care team or play other roles. And as far as all the sort of collaborative innovation work, there's so many opportunities. My favorite one is that our palliative care team right now is being actually led by one of our accountants, because we understand that people can get involved without needing to be the subject matter experts. They just need to understand how to be leaders, to gather information, to lead the process, and to have subject matter experts in the room. This is a quick nod to the payment model problem. If you start at the top with the total cost of care and then you reduce it by that first incremental amount and you have a 50-50 shared savings, then you each get half. But if the performance period ends and the payer says, well, this is the new normal and you have to lower it again, then this is what happens. Now you only get half of the increment, and as a provider, you're giving away 3/4. And then you might get to a place where you just can't take any more costs out of the system, total cost of care out of the system, if in fact you're in one of these models where you just compete against yourself, and then you're still delivering all that value, but you're not capturing any of it. So, this is a place where like a percent of premium model might make more sense for a provider organization. But we're going to do better than we did last time is not a payment model that you can stay in forever. And that was really the same problem for some of the entrants into the MSSP that I showed you before. It's definitely been worth it. I think if we had it to do all over again, we would do it. There's definitely been white knuckle moments, but we think having a majority of patients in a shared savings model is key. You absolutely have to spend more to save more. Our incremental costs today, if we said, gee, let's just go back to doing fee-for-service the old way, our incremental costs are probably $12 to $13 million a year on total revenues of maybe 75. So we are taking a huge investment risk here, right? But it's working. So we've done well by doing good, which is what we wanted to do. We wanted to do good for our patients, and we wanted to be financially successful, and we've been able to accomplish that. What would our docs tell you? They would tell you that care is better. I mean, we started with diabetes out of control metric at 20%. So when we started this work in 2011, 2012, 20% of our diabetics were with an A1C greater than 9. That's about national average. We're at 7.6 now. And the docs know it wasn't them that really did that. It was the pharmacy team that leads our high-risk diabetes management program. It was 130 education classes a year, phone calls to these patients every 2 weeks. Now we even have glucometers that send the results of the cloud in real time, and our teams can look at it right away. Incomes are good, they're better. We've been able to share the success. Actually, for the last 3 years now, our executive team has gone out and met with every employee of the company, 650 people. Everybody gets a bonus. For the frontline staff, it's been a week's pay for receptionists or MA because everybody's had to do extra work here. And they also are understanding of and motivated by what we're trying to accomplish. So we also talk about our quality performance to the MAs and secretaries, understanding that they work in healthcare for a reason. There have been trade-offs. There's extra work here. There's no doubt about it, and we still need to particularly reduce the documentation burden for our docs. But team-based care has become the new normal. Our docs really like it, especially working with the pharmacists and nurse care managers. We have integrated behavioral health coming online in several places, including disease management. So, I go back to these questions because I think they're the important ones, and it's really been interesting to be here and be part of this larger conversation about, how do you get this done? Because the solution for Kaiser is not going to be the same solution that a small practice is going to have. A solution for your system is still going to be different than the one we have. I think there is a question about how small and independent can practices be and do this. And I came from that. I worked in a 2-doctor practice for 4 years, and for the first 15 years at Coastal, not that much was different. But getting claims from every payer and running analytics on it yourself and understanding what that means and pulling opportunity out of that, using that data to drive clinical programs. These things all sound good, but you have to know who to offer them to. You have to know how to reach out to those patients proactively. That is a bunch of work, and the contracting burden is massive too. You need a team of people to do that. And now we've got an actuary and retainer. This is the world that we're in. But it's a righteous thing because the outcome's been great in my opinion. So I'd be happy to take any questions.